Jason, I think you're muted.
Oh, sorry. So looks like we have some deviation of that spinous process to the left.
Okay.
The defect there in the pedicle there, or the lamina there?
Okay, so this is one cut. This is another cut. So you're talking about right in through here. Okay.
Yeah.
And then, but I think that's kind of cutting underneath the lamina. What do you think about the foramen on the right side here?
It is definitely larger than the left side.
Okay. Right, and then let's go to the sagittal images. This is what the sagittal images look like.
All right, so the L45 and L5S1 sharing of foramen there.
Okay, so this is an absent right L5 pedicle, and a typical deviation of the spinous processes is seen in this particular congenital anomaly.
Okay.
Okay, Robert.
All right, so here we have a couple CTs of the L spine. It looks like there's, some transitional lumbo-sacral anatomy with partial fusion of that left transverse process and sacrum there.
Right. So what would you call this syndrome?
It's Bertolotti's.
Yeah, right. And some people also call it hemisacralization at L5, but this would be Bertolotti's syndrome. And I would just describe it, there's that classification system, but I think once you recognize it, if you just describe it, and when it's asymmetric like this, it tends to be most symptomatic. Okay, Dan?
CT at the level of L5, presumably. Looks like there's like a bipartite. Yeah, sorry. CT at the level of L5, close to the sacrum. Looks like there's like a bipartite vertebral body, possibly.
So looks like there may be a sagittal cleft in L5. Here are the coronal reconstructions.
So it's the.
So this is called a sagittal cleft.
Okay.
And it's a congenital anomaly here. And then
would that be a spina bifida there also?
Back here, I'd need to see the rest of the images.
Okay.
Okay. So here, this actually again shows kind of a cleft in the middle, and this can also be called a butterfly. Yeah. Elior?
Right, so in this vertebral body, there's this linear signal, low signal on T1 and T2. It looks like a cleft.
Yeah, it looks like kind of cartilage, right? Yeah, so this is another cleft, and so this is another butterfly vertebra. And on the sagittal images, this is kind of what it looks like when you go through that cleft. Okay, Tayson.
All right, so definitely looks like we have some collapse of that vertebral body there. L1.
It looks a little bit odd here in the coronal.
Yeah, it kind of looks like an incomplete cleft there on the axial.
On the scout view here, and here we can see a cleft in the middle here. So again, this is kind of has a sagittal cleft. And whenever you see congenital anomalies, you have to look for others because they often come in groups. Do you see anything else here that you'd want to comment on?
Probably diastomatomyelia.
Right. So it looks like the cord is in two pieces here, right? Okay. Robert.
All right. Here it looks like there's almost a abnormal signal at the level of L3. Looks like maybe like a fibrous band or something, but I want to see some axial imaging through that.
Okay.
Yeah, so it looks like a cleft and it looks almost osseous to me, and then there's a
Yeah.
yeah.
So it can be fibrous, or you can just have nothing in between the two, just a separated cord. But often it's fibrous. And it can be bony, as we talked about yesterday. And this is a bone stuck in between the two, chicken bone. Okay, Dan.
34-year-old male complaining of a lower leg weakness. On the scout, they look pretty healthy, skinny. I can't really see much. There we go. So it looks like at L5S1, there's like
So the thing to notice here is that you've degenerative disc disease, but notice at each of these levels, it looks like you have kind of a protrusion of the edges of the vertebral bodies into the neural canal with central stenosis at every level here. So what might you be thinking of? Let's see. And here on the axials, you can see
yeah. So here's stenosis.
the stenosis.
Um,
And this is typical of achondroplasia.
That's what I was thinking, but I was looking for like the is it the hourglass shape of the pelvis?
Yep. Okay.
Okay, so
In my experience, all the achondroplastic dwarfs had back problems, which was their main complaint.
Thank you, John.
I saw quite a few.
So we're looking at L3 on the axial. So I think looking in the spinal canal, yeah, we should see some cauda equina there,
Yeah.
but they look, kind of bunched up.
So this is a low-lying conus, and you look to see if it could be tethered cord, but sometimes it's not. It's just a low-lying conus,
Okay.
and that's what this was. Okay. Tayson.
All right, so there's this fluid-filled structure in the left facet joint there at L5S1.
What's it filled with?
Probably synovial stuff there, right? Like a synovial cyst coming from the facet joint.
So this is T1 and this is T2.
Oh, yeah. So it's fat.
And there's just the next cut over. And you can see here's that area on the sagittal T1, T2, and this is stir. So it suppresses with the stir, so it is fat. And this is a facet lipoma.
Okay.
Robert.
All right, so here there's abnormal morphology of the spinal, thecal sac posteriorly there, and then in the posterior epidural space, it looks like there's a lot of, T1 and T2 bright signal back there that fat sets out. So is that like epidural lipomatosis?
Right. And you can see how it can actually narrow it can help produce central stenosis in this case, put tension on the nerve roots. Okay. Dan.
Okay, so sagittal T1 and T2 images showing T1 bright, T2 ISO, I guess, maybe a little signal. It looks like it's actually attached to the spinal cord. It looks like there's like a cleft in it.
The cord is way up here.
Oh, yeah.
These are the nerve roots coming down here. This is actually a true T2, which you never see anymore. This is not a fast Spinal T2. If you have a true T2, the fat's not bright. The bright fat is an artifact of the fast Spinal technique when you do T2s with fast Spinal. So you won't see this kind of study because they take very long time, like 20 minutes to do. But in the old days, that's all we had. And this is just a lipoma. And you can see absence of the posterior elements back here. So this is a congenital lipoma with congenital absence of the posterior elements. And here's another example. And then
We don't have symptoms that we know of.
I don't know what the symptoms were, John.
Okay. I would imagine there would be quite a few.
Yeah.
Right, so this another mass in the spinal canal that's okay, so on the left is that a T1?
This is a T1. This is a T2.
Uh-huh. So it looks like fluid. It's dark on T1 and then bright on T2, so I think it's a cystic structure.
There's that, and then there's this. And then there's a big defect back here, right?
Yep.
So what would you call this?
Yeah. Chiari II, okay.
Okay, this is a Chiari II malformation. We do the cervical spine, we'll talk about the Chiari 1, 2, and 3. Chiari 2 is where you have a Chiari 1, and then you have this defect in the lower lumbar spine. So if you see it and they have symptoms, and these people all have neurologic symptoms, or most of them, you then have to go down and do the lumbar study. And then this is the cervical spine for that patient. So what do you see here?
Low-lying cerebellar tonsils,
Right.
the syrinx.
Yeah.
So, yeah.
And some cord atrophy. Yeah. So that's this alone would be a Chiari 1, and then with the lumbar findings, it's a Chiari 2.
Mm-hmm.
Okay, Tayson.
All right. So it looks like we're probably at the S1 level.
Yes.
Those nerve roots look very enlarged.
Okay, right. So what can produce enlarged nerve roots?
I was thinking maybe Charcot-Marie-Tooth.
Yeah. Yeah, so there's a little bit of a differential, though, Charcot-Marie-Tooth for diffusely, but here, notice that higher up, the nerve roots are pretty normal. So we've got a few large ones down here, but if we go up a little higher, we're not seeing thickened nerve roots in the other areas. So if this were Charcot-Marie-Tooth, we would expect all of these nerve roots to be thickened. So what else could cause thickening of the nerve roots?
Okay, enough of that. Okay.
So this is neurofibromatosis. Yeah. Okay, Robert?
All right. here looking at the L spine, superiorly there's a Facet bright structure back there. I want to see, yeah. So this again looks like thickened nerve roots or some sort of structure.
Now notice that how large the neuroforamen is here on the right side, and it's normal on the left. So that lets you know that this has been here a long time. So what do you think it might be?
Would this be another neurofibroma?
And here you can go out and see that it's very thickened nerve root extending out into the soft tissues, and that's a neurofibroma. Good. Okay. Dan?
Chronic low back pain. So, sagittal view. Posterior elements. Okay. Nerve roots look okay. Maybe a little thickened.
Okay. Here's the sagittal midline cut. Does that look like a normal cauda equina?
No, looks thickened and
Yeah, the axial edges.
yeah. Yeah, that's the most horse's hair I've ever seen in a cauda equina. Distally, more distal, I think that is. Looks like they're clumped a bit.
What?
Are they clumped a bit, more distal?
No, they're not clumped. They're just big.
Just thickened.
So what might you think this would be?
Okay, so that's
So this is Charcot-Marie-Tooth.
okay.
And it can be variable. It can just be the lumbar. I've seen higher levels be relatively normal, and the lumbar just thicken like this. But it tends to be more diffuse and symmetric than neurofibromatosis. Okay.
And they grow with age, don't they, John?
The nerve roots thicken with age. Is that what you're saying?
Yeah,
That I don't know, actually, John. Is that right?
I think they do. You don't see that in children so much.
I didn't know that. Thank you.
57-year-old male, chronic knee pain and low back pain. Subchondral bone in the femoral condyles. It's increased signal. Serpiginous signal could be osteonecrosis.
Okay, could be osteonecrosis. Here's what the lumbar spine study shows.
Yeah, those nerve roots look thick in the edematous.
These are probably okay.
The ones in the
Yeah.
foramen,
The
though.
ones in the foramen don't look like it. Okay.
Huh.
We go farther down. So
Yeah.
above they look pretty normal, but now we're seeing that they're thickened
Yeah,
on both sides. And look out here how thickened they are.
yeah.
So this seemed odd to me that they were normal inside the cauda, but when they came out, they were thickened. And this is, see how thickened they are?
Yeah.
And this is neuropathic knee due to Charcot-Marie-Tooth. Now, Charcot-Marie-Tooth is not one disease. It's genetic, and there are a number of genetic mutations which can produce a Charcot-Marie-Tooth symptomatology and disease. Okay, Tayson.
All right. Gait disturbance at age 1, crow's feet walking.
That's from Korea.
I mean, I guess the nerve roots are kind of diffusely enlarged.
Right.
Just for a moment.
All of these levels. So here the cauda equina is all thickened as well as the nerve roots
Yeah.
of the neuroforamen. Here we see. So other things that can do this are chronic demyelinating inflammatory polyneuropathy, which I've never seen, hereditary motor and sensory neuropathy. There are a bunch of these that are due to individual genetic mutations, which can produce similar kind of output. Most of these are kind of put under the term Charcot-Marie-Tooth, neurofibromatosis 1. And you can also get peripheral neurolymphomatosis that can produce diffuse thickening of the nerves. But by far the most common one that I've seen in practice is the Charcot-Marie-Tooth.
Tyson was bigger, a crow or a raven?
I am not sure.
Raven.
Okay.
But they're very difficult to tell the difference when you watch them fly.
Okay. Yeah. So this was Charcot-Marie-Tooth 1A. And now I think this was a few years ago. I think there are more types that have been described now. And, you tend to get a stork leg, inverted bottle, but past cavus are classically associated with it. And histologically, it has a very characteristic histologic appearance. And a few other differentials, including leprosy, sarcoidosis, and amyloid. Okay. Robert, are you next?
Yes, I believe so.
Okay.
So we have a 30-year-old male with back pain. It looks like there's some sclerotic foci, posterior vertebral body, and pedicles bilaterally. And yeah, posterior elements as well. Here, again, there's some decreased signal posterior vertebral body of what that looks like, L3 maybe. So sclerosis, I would think.
So kind of odd appearance.
Yeah.
In a lot of different places.
Mm.
So what are you thinking about?
I mean, just with that appearance, I'd be concerned about, sclerotic mets, but
Okay.
I don't
Here's
know.
what the kidney looks like,
Uh,
and here's what the brain looks like.
the kidney looks like there may be a mass centrally there.
Okay. So what you have are sclerotic areas in the bones, kidney mass, and then you have these calcification in the basal ganglia in the brain. And this is tuberous sclerosis. Okay. Dan.
50-year-old female, axial view, CT shows some thickened trabecula. Differential right now would be like Paget's.
Okay. You can see it there. Here's the MR. There's
Yeah.
the MR.
I mean, still, that doesn't look like too thick to be hemangiomas.
Okay, so it's pretty diffuse for Paget's. Paget's
yeah.
usually is more localized. And this is osteopathia striata.
"15-year-old, low back pain for a year." The end plates on the, they're more sclerotic than the rest of the vertebral bodies. Yeah,
The bone scan.
bone scan. I'm not sure there's increased uptake in the spine. In the skull looks thickened.
A little bit. So this is osteomesopyknosis. It's autosomal dominant. And yeah. It's another form of osteosclerosis, of which there are a number, but so usually in the second decade of life, and you can get these sclerotic changes. Okay, so here you go. So I'm gonna stop now.